Good evening, everyone. I'm Tony Segreto, and once again, honored to be your moderator for tonight's all-important In the Know Town Hall. Tonight, we're going to focus on our hearts and the key innovations at UHealth driving heart health. And with February being American Heart Month, we're entirely on topic. You know, it's a perfect time to get a sense of the latest advancements in cardiovascular care. But first, we need to be clear and upfront about the importance of this topic. According to the CDC, one person dies every 36 seconds from cardiovascular disease. Think about that for a minute. One in every 36 seconds, a person dies from cardiovascular disease. That's a staggering number. It's the leading cause of death in the United States. Well, thankfully, we have an extraordinary team of physicians and researchers at UHealth who have dedicated their lives to protecting and improving your heart health. Our panelists tonight include some of the most prominent experts in cardiology, interventional cardiology, and cardiothoracic surgery. They're going to help us explore the newest innovations in research and treatment. Join me in welcoming Dr. Joseph Lamelas, Chief of the Division of Cardiothoracic Surgery, who is world-renowned for developing minimally invasive valve replacement techniques and surgical interventions. In fact, he developed a series of repair and replacement valve techniques that we call today the Miami Method. Also with us tonight is cardiologist Dr. Maureen Lowry, Medical Director of UHealth's Cardiovascular Non-Invasive Diagnostic Labs. She's also the Professor of Medicine and Vice Chair of Faculty Development and Diversity for the Department of Medicine. And joining Dr. Lowry on the panel is Dr. Carl Oringer, Director of Preventative Cardiovascular Medicine and Professor of Clinical Medicine. As you can see, this is the wow factor tonight, folks. It is truly a world-class group of experts, an amazing group of doctors. Now, before we get started, let's go over how you can participate in tonight's conversation. After Dr. Lamelas has delivered his opening remarks, all panelists will answer the questions that you've submitted over the last few days. But you're also going to have the opportunity tonight to submit your questions live during this next hour. For those of you who have been with us before, you know the drill. For those of you who are new, look at the bottom of your screen. You're going to see a Q&A feature there. With that, you send us your questions. We want to tell everyone and remind everyone as well that all of your questions are sent in anonymously. And we promise, we really do promise, we're going to try to get to as many of them as we can. As you can imagine, we are going to have a lot of questions tonight. We already have a lot that you've sent in over the past few days. So let's get started. It is now my pleasure to bring in Dr. Joseph Lamelas. Dr. Lamelas, so great to have you. And thank you for taking the time to spending time with us tonight.
Great. Thank you, Tony. That was a very nice introduction. I'm very delighted to be here tonight with everybody and with my colleagues. And just so everybody knows, I'm the chief of the Division of Cardiac Surgery at the University of Miami Miller School of Medicine. And this meeting tonight is focused on the heart because this is Heart Month. And I just want everybody to know that the team that you see here tonight, as well as everybody at UHealth, dedicates every waking moment to advancing cardiovascular care, both in the lab and also in real life, taking care of patients. And, since cardiac disease is the #1 killer in the United States, this month is very important for us because it brings attention to this disease that we all hold close to our heart, in fact, as well. And at UHealth Tower, we deliver very simplistic approaches to the heart, as well as that begins with diagnostic testing, that up to very extreme treatments, as well as we are the leading minimally invasive cardiac program, I would say, in South Florida, but also in the country. And we'd be happy to share more on what we do. And some of the questions tonight will be focused on that. So I'm here with two of my esteemed colleagues. And as you know, from my standpoint, my practice is focused on cardiac surgery, and I operate on every different pathology in the heart. The only thing that we don't do at UHealth is transplant, that is done at Jackson, but I perform the bread and butter cardiac surgery, which is the sternotomy-based bypass surgery, up to the very advanced minimally invasive surgery, which is a very complex operation performed through 2-inch incisions on the right side of the chest. including repair and replacement of one valve, multiple valves, repair of congenital cardiac defects, repair of removal of tumors within the heart, and in addition to replacing the ascending aorta and the arch. And I'm proud to say I'm one of the few surgeons in the world, if not the only surgeon, that does this operation through a 5-centimeter incision between the ribs without breaking the ribs and going through this access point with special instruments and doing these complex surgeries. So as I'd also, this is what I do, but I also would like my colleagues, Dr. Oranger and Dr. Lowry, just to mention what they do so you have an idea, and then we could go into the questions and expand on the different pathologies that we treat and the different treatment options. So Dr. Oranger, maybe you want to start?
Well, thank you. I appreciate kind words from Dr. Lamelas. And first of all, I'm very privileged to work with doctors like Dr. Lamelas and Dr. Lowry because we work as a team. Our objective is to think about every aspect of cardiac care and to try to work together to provide the best care for our patients. My focus is on prevention. So many of the problems that we encounter in cardiology, whether it's coronary artery disease or whether it's problems that relate to many other issues, arrhythmias, the entire spectrum of cardiology, many of those can be prevented with really good preventive care that includes addressing the risk factors that cause cardiac disease and taking care of those risk factors as efficiently as we can. So tonight we're going to have the opportunity to talk to you about some of the early diagnostic tests that we do to try to find heart disease at its earliest stages, and also some of the very exciting approaches that we plan to take as we move forward to identify heart disease at an even earlier stage than is done in almost every other place in the country. So I will now turn it over to Dr. Lowry.
Good evening. It's an honor to be here to talk about something so close to my heart as heart disease in women. Not only being a woman and caring about my heart, but yours also. I hope to cover tonight the gamut of heart disease in women to include young women as well as old women. Heart disease is a disease of all ages of women. So I'm excited to be on a panel with Dr. Lamelas and Dr. Oranger. And I'm also involved in the diagnosis of heart disease in women. And I want to touch on that and the importance of getting screened for heart disease. So thank you and welcome.
Well, doctors, thank you for joining us. Dr. Lamelas, that was a great opening. Thank you for all you do for us. And Dr. Oranger and Dr. Lowry, we're looking forward to a great hour. So let's turn our attention now to the questions that were submitted by some of you. Our first question is for you, Dr. Lowry. Do men and women experience the same symptoms associated with heart disease?
The answer is yes. Women can have the same symptoms as men when having a heart attack. And a heart attack is the example that is most commonly used as an example. So women can get oppressive chest pain as an initial symptom of heart disease. However, women tend to have more atypical symptoms. And by that, they have more nausea, more vomiting, more sweating, more back pain, jaw pain, pain anywhere actually. And because these symptoms are different, it delays the women in seeking early attention or arriving at the emergency room in excellent time so we can save more of their heart. So the answer is yes, but the answer is no. Rosie O'Donnell had a mnemonic when she had her heart attack. She's a famous comedian, and I'm not preaching HIPAA here. She did an HBO special on this. And she came out with a mnemonic called HEP, HEP, HEP. And any of those symptoms qualify as a woman to seek urgent health care. And the H stands for heat. You become very hot. E for exhaustion. Despite how much sleep you get, you're still exhausted. P is for pale. The other P is for puke. And the final P is for pain anywhere. She actually presented with bicep pain in both of her arms. So again, do not underestimate the significance of your symptoms and seek early care. If there's any question, it could be your heart.
Thank you, Dr. Lowry. That was wonderful. Dr. Oranger, you're up. We welcome you tonight, sir. And we thank you for being here. My doctor ordered a coronary calcium score. Are there new uses of the results of this test to help personalize treatment for heart attack prevention?
Well, thank you for that question, Tony. In fact, that's one of the very exciting applications of early detection and prevention of cardiovascular disease. You know, we've begun to recognize in recent years that the older approach of getting a stress test for somebody who wonders if they have heart trouble is actually not a particularly good way to do it. In fact, it gives us very late information about whether a person may have significant cardiovascular disease. So when we have a person who does not have current cardiac symptoms, but who may harbor several risk factors for heart disease, such as high blood pressure or diabetes or smoking or a family history of early heart disease, we oftentimes will consider doing a coronary calcium score, which is simply a very rapid CT scan of the heart, takes 5 to 10 minutes. There's no IV involved. And it lets us know whether there's any evidence of hardening in the walls of the arteries of the heart. And what we know is that calcium goes where cholesterol goes in the artery wall. So we can't see cholesterol, but we can see calcium. And so if we see a lot of deposits of calcium in the walls of the arteries that supply the heart, we know that a person has a lot of cholesterol plaques, these little islands of fat that can get bigger and bigger and finally rupture and break, causing a heart attack, and then requiring either an acute intervention or when we have experts like Dr. Lamella, sometimes an operative approach to basically save the person's life. So our job is to try to detect these problems much earlier. And we've now recognized that as many as half of the patients who are normally prescribed a statin medicine, for example, because they're kind of at an intermediate risk for heart trouble, may actually have no coronary calcium at all. And in fact, such individuals are very unlikely to benefit from the use of statins or other preventive treatments, aside from lifestyle, like improving their diet or doing exercise. So it's very important in the case of prevention to think about the use of a coronary calcium score, particularly in people in their middle years who harbor a couple of risk factors. The other newer use of coronary calcium that's going to be part of our next set of guidelines, cholesterol guidelines, is the use of the amount of coronary calcium you have to determine the intensity of treatment. So we're now recognizing that not only do we use coronary calcium to determine if the basic forms of treatment like statins are beneficial, but now we have determined that depending upon how much coronary calcium you have, it may help us to decide exactly how much treatment you need to prevent heart disease. So all of these are exciting uses of coronary calcium, and we do all of those in our prevention program at the University of Miami.
Exciting indeed, Dr. Oranger. Thank you. Dr. Lamelas, what are the true advantages of a minimally invasive surgical procedure? And is minimally invasive better than open heart?
A minimally invasive operation is one that's done through a small incision. And just for a little background, cardiac surgery was one of the last specialties that embarked on lesser invasive approaches because everybody was uncomfortable operating on the heart through a small incision, because classically for many years, the operation was done through a full sternotomy. So the chest cracked wide open, the heart totally exposed. And then we went into lesser invasive approaches, which are operations that are done through small incisions. And this is the least traumatic route to the heart. And in the operating room, this translates into less bleeding because obviously there's less tissue trauma. There's less transfusion, so that's definitely a benefit for the patient. And the patient's, the recovery in the ICU, in the hospital, and back to a normal lifestyle is significantly improved compared to the full sternotomy, chest wide open approach. And it's really a drastic difference when you compare the recovery with these patients and the sternotomy patients. And then psychologically, a lot of the patients, since they have not had that big operation, they feel that, many of them tell me, I don't feel like I have any heart disease because it was done through such a small incision that the recovery was so quick. And last but not least, from a cosmetic standpoint, this especially for female patients and a lot of male young patients who are vain, it does have a tremendous impact. But from a recovery standpoint, and also one thing that's not even mentioned, if this patient ever needed a reoperation, a second time operation for whatever reason, the entry into the chest is a lot less risky, and it's almost equivalent to entering the chest as a first time operation, which is also very important.
Thank you, Dr. Lamelas. Dr. Lowry, is it true that women get diagnosed with heart disease much later in life than men do? And why is that?
So it's long been held that estrogen somehow protects us from getting heart disease. So this estrogen protection lasts us at least to the menopause. So if you date heart disease in women as compared to men, it's more related to their menopausal status other than their age. So years ago, I used to ask the medical student who gets heart disease, and the answer came out: middle-aged men, and old women. And it was because of this estrogen protection effect. And even though that is true, some of that is undoing itself due to the onset of massive obesity, as we see in our females. So the onset of obesity is actually giving us more heart disease in younger middle-aged women than we used to see. But it is this background of estrogen that led to the studies. Does estrogen help women? And I think that's going to be discussed later on. But it's the estrogen protection is the answer.
Thank you, Dr. Lowry. Dr. Oranger, I have heard about artificial intelligence. Can this technology be used to detect and prevent heart attacks?
Well, you know, artificial intelligence really is a process in which huge amounts of data are put together to make sense out of various types of testing procedures. And so, in fact, there have been studies that have been done in which radiographic procedures, various types of X-rays are looked at, and with the human eye combined with the use of artificial intelligence to really integrate large amounts of data, we can detect things more accurately and earlier. So artificial intelligence has been used to, for example, look at mammography to earlier detect breast cancers. It's also been used to earlier detect skin cancers. But the application of artificial intelligence to imaging is something that we're now finding is a very exciting frontier in medicine. And in fact, the University of Miami has just received approval to be integrating an artificial intelligence system into our looking at chest CT scans to detect coronary calcium at an earlier stage. So let me explain a little bit about what this is about. We know that most chest CT scans are done to look for problems in the lungs, or sometimes in the area between the lungs and the mediastinum. But in fact, there's very important information that can be actually derived from looking at these chest CT scans that can give us information about whether there's calcium in the arteries of the heart. Now, this is different than a coronary calcium score, which is a dedicated test to look for coronary calcium. But with a chest CT, we now are able to find the presence of coronary calcium and actually quantitate how much of it is there. Now, radiologists are able to give a reasonable estimation of how much calcium is there, but now with the use of artificial intelligence, we're now able to determine this much more accurately and at a much faster rate. So I think what makes me very happy is that the University of Miami is now one of 4 institutions, 2 in California, the Mayo Clinic, and now University of Miami, that is actually integrating the use of artificial intelligence to detect the presence of coronary calcium on chest CTs that are done for other reasons, and now begin those patients on preventive therapy to help to prevent coronary artery disease and heart attacks.
Wow. Wow. How fortunate are we to be one of the hospitals? This is great. Dr. Lamelas, first of all, you have to be so proud, Dr. Lamelas. Like you said earlier, what an esteemed group here. It's really something. Which specific operations, Dr. Lamelas, can be performed through a minimally invasive surgery? What is it in particular?
And so basically, we have an all-comers approach to minimally invasive surgery. And with that, I mean, operating on one isolated valve, both repair and replacements, or multiple valves, 2 or 3 valves, and also operating on valves on both on the left side of the heart and the right side of the heart. And some of those are through different approaches as well. In addition to repairing congenital cardiac defects, not reoperation from somebody who had a pediatric operation and then they need a more complex surgery. That we hand over to our pediatric cardiac surgeon, who's Dr. Molinari, and he's an expert at this. But the minimally invasive surgery, again, multiple valves, one valve, multiple valves, repair, replacement of each of the valves, resection of intracardiac tumors, also replacement of the ascending aorta and the hemiarch. And again, that's done not violating the sternum wall through a 5-centimeter incision between the ribs, in addition to arrhythmia surgery and finally also bypass surgery. But the bypass surgery I limited to just one single bypass on the left side, which is the left anterior descending artery, which is the most important artery the heart has. So it's a multitude of different pathologies that could be addressed. And it's an operation that I've had a tremendous amount of success with and have benefited many patients utilizing this approach.
Thank you, Dr. Lamelas. Dr. Lowry, what are female-specific disorders that increase a woman's risk of heart disease?
So I want to stress first that traditional risk factors hold for women too. And I just want to mention one that's very important to my heart: obesity and diabetes in women. Terrible combination. So it negates this female advantage of estrogen at any menopausal status. But other things that women don't realize is pregnancy. We think of pregnancy in young, healthy women. Pregnancy itself is something like a stress test in some women. And it's actually has been now shown, and it's actually in our guidelines, that if you have complications pertinent to the heart in pregnancy, they can confer long-term risk, specifically preeclampsia. That's when you're pregnant and your blood pressure goes very high, requiring urgent removal of the fetus or delivery of the baby. Gestational diabetes is another gender-specific risk factors for heart disease in the future. Other things are depression and very arthritides that are more common in women, such as lupus or rheumatoid arthritis. So these are very specific risk factors for women for future heart disease.
Thank you, Dr. Lowry. Dr. Oranger, you touched on this. What new medical treatments are coming in 2022 to prevent heart attacks and strokes?
Oh, this is such an exciting time in the whole dimension of prevention of heart disease. We have been very fortunate to have treatments that very, very effectively lower LDL cholesterol, the so-called bad cholesterol. And in general, our first approach is to use the best we can of dietary treatments and exercise. We counsel all of our patients on the importance of heart-healthy diets and doing regular aerobic activity. When that is insufficient, or if a person has a severe enough condition that they are really at high risk, we then move to the use of statins, which are medicines that significantly lower cholesterol, may lower cholesterol by as much as 50 or 55%. There are other generic medicines also. One of the more commonly used generic medicines is ezetimibe, which reduces the absorption of cholesterol from the intestines. And then there is a newer category of drugs called the PCSK9 inhibitors. These are injectable medicines that are given under the skin every 14 days that can provide an additional 60% reduction in LDL cholesterol. So you might say, wow, we're really dropping the bottom out of the cholesterol. And we are, in fact, doing that. We have lowered the LDL cholesterol in many people to less than 30 milligrams per deciliter, which is extremely low. And it seems like these treatments are very, very well tolerated and tend not to cause any major significant worrisome side effects. Now, the FDA just approved a medicine called inclisiran. Inclisiran is a medicine that is used based on an initial injection, an injection in 3 months, and then only given twice a year, and causes sustained reductions in LDL cholesterol of at least 50%. Now, in addition to that, there are other newer medicines that are being developed to address high triglycerides and to address another type of bad lipoprotein called lipoprotein A. All of these used together are going to be more and more effective in helping us to reduce the risk of cardiovascular disease, especially in high-risk individuals.
Again, in your words, very, very exciting time. Thank you, Dr. Oranger. Dr. Lamelas, are there specific criteria I would need to meet to be considered for a minimally invasive heart surgery?
Right, so that's a good question. It's a question that I'm asked often. As I mentioned earlier, we use an all-comers approach to minimally invasive surgery, but there are a couple of patients, a couple of groups of patients that that we cannot offer this approach. For instance, if somebody has significant coronary disease with valve disease, if they have concomitant disease, coronary and valve disease that require bypass surgery, then those cases we'll do through a traditional sternotomy. And the only other operation that is not performed through a minimal invasive approach is a valve sparing operation. So for instance, if you're a young patient and we want to spare your aortic valve and not replace it, that operation requires a lot more exposure, and it's a little more of a traumatic operation. So we need to have a lot more exposure to access the valve and the ascending aorta. So basically just two groups of patients that we don't offer to. But having said that, if a patient has coronary disease, blockages in the arteries, maybe one or two that could be addressed with a stent, then a stent is placed by the cardiologist, the interventional cardiologist beforehand. And then I will take that patient to surgery, even on, significant blood thinner, and perform the operation. Again, I'm not worried about bleeding in these operations because these operations probably have the least amount of bleeding compared to any cardiac operation. So again, if they could have a stent, they could have the isolated valve surgery or double or triple valve surgery, even on blood thinners.
Dr. Lamelas, thank you. And Dr. Lowry, I'm sure you get this question quite often. When should a woman start regular consultation with a cardiologist?
I do get that a lot, and it's one of my favorite questions. Number one, symptoms. Any symptoms, especially if they're driven by activity or emotional stress. So any symptoms you're having that's limiting your exercise capability, or all of a sudden you're noticing that you're decreasing your exercise tolerance, that should warrant investigation. Women that are at high risk, these are women with known heart disease that have had a heart attack or a stroke, or have known pain in their legs when they walk. These should be evaluated immediately. Women who are at risk, these are women with one or more risk factors, especially if they don't modify their lifestyle with exercise, proper diet, as Dr. Oringer was alluding to. So again, when in doubt, get it checked out is my motto. And at the University of Miami, we have many levels of expertise to evaluate you, from the calcium scoring that Dr. Oringer was alluding to, as well as stress tests and echoes and the whole spectrum of diagnostic testing.
Dr. Lowry, great. Thank you so much. Dr. Oringer, what is the current thinking behind calcium supplements or Boniva if one has calcification in the arteries?
So this is a commonly asked question, and people always wonder if they have coronary calcification, does ingestion of oral calcium make a difference? And the best evidence suggests that it doesn't make a difference if you need calcium for bone health, or if you have other bone disorders. You're probably safe with regard to coronary calcification.
Great, Dr. Oringer, thank you. Dr. Lamelas, I have heard of individuals who have had bovine animal valves that have failed. Is there any new research or innovation around artificial valves or regeneration of new valve tissue?
Right, that's a great question, and that's a topic of ongoing investigation in cardiac surgery. So basically, just want to break it down very simply. There's three types of valve replacements that we have today. One are tissue valves, and the tissue valves are the pig valves or the cow valves. So what they do, just a little out of curiosity, they grow pigs, and out of every 100 pigs, 10 pigs are chosen they harvest the valves to be used in these artificial valves, and these valves are sutured by hand. And then they actually grow little piglets for the smaller valves as well. So it's a very tedious process to harvest the valves and to implant it. From the cow valves, the tissue comes from the pericardium or the sac around the cow valve, and those are laser cut and again hand sewn into these little frames. And then we have the mechanical valves, which are made of a metal called carbolite carbon. And there's different types of valves and then the third group are the cadaver valves, which are called the homographs. And those are valves that are harvested from people who have passed, and we utilize these valves. Specifically, the main use is when the tissue valves become infected. This is probably the best valve replacement therapy that we have today. So if you're using a tissue valve, we usually place these patients on aspirin. If you use a mechanical valve, the patients need to be on Coumadin, which is a stronger blood thinner, and you need to have, the maintenance is a lot more with a mechanical valve. But then there's different investigations ongoing, utilizing different types of blood thinners that may potentially decrease or eliminate the fact that you have to take Coumadin. As far as artificial valves, the newer ones, there's a few that are being developed now with different types of tissue replacements. So there are valves that are being generated with that are not pig or mechanical, that hopefully will have a decreased amount of anticoagulation requirement. But the big thing with all valves is to try to develop a valve that'll last long. If you implant the tissue valve in a young patient, it will not last. It may last 5-10 years. I've had them last 20 years, but that's very rare. The older the patient, the longer the biologic valve or the tissue valve will last. Mechanical valves can be implanted at all ages, but again, we have that problem with anticoagulation, which older patients may not be able to tolerate. As far as regeneration of new valves, there is ongoing studies with that as well, where a biological scaffold, or almost like a frame, is developed, and then the patient's own cells are grown on this frame, and then they ultimately take over this biological scaffold, and those would probably be the most similar to our native valves. But again, this is not prime time yet. It's all still investigational. Hopefully one day we will develop a valve that'll last forever. But keep in mind, our own valve doesn't last forever. So I don't know if everything lasts forever, but one day we'll get there, I'm sure.
Well said, Dr. Lewis. Thank you so much. Dr. Lowry, is the University of Miami doing anything unique to their approach of patient care for a woman who's presenting symptoms of heart disease?
Well, we certainly don't underestimate the symptoms in women. That has been kind of one of the taboos in emergency rooms. Do women get equal care? What we are doing at the University of Miami is addressing seriously the risk factors to avert or decrease your risk of having an event such as a heart attack or stroke. We have Dr. Oringer and his preventive armamentarium that he's been discussing this evening. We have the only certified Center for Treating Hypertension. And by that, I mean not only identifying it, but getting those numbers to goal and keeping them there. We also have diagnostic testing that will supplement the regular testing for men, as women have more abnormal resting EKGs. So we have the whole armamentarium to diagnose a woman. Do we have something called the female stress test? No, not exactly, but we certainly have the expertise to deal with any woman with any kind of heart disease.
Thank you, Dr. Lowry. I'm sure women have a lot of stresses that we're not even aware of, that the men
We
don't
do.
know about. Yeah.
We
Thank
hide
you.
them well. That is the problem.
Yes, you do. Thank you. Dr. Oringer, is it always the bad cholesterol that is the culprit of heart diseases, or is it sugar? And when is it necessary to take cholesterol drugs?
So that's one of my favorite questions about the so-called good and bad cholesterol. Traditionally, we've been taught that the HDL is the happy or good cholesterol, and that LDL is the bad cholesterol. And if you look at large populations of people, in large populations, those that have higher HDL levels actually have lower risk. But for a given individual who comes into our office, a high HDL, a medium HDL, or low HDL, we cannot tell what that means in terms of cardiac risk. So in fact, the previous thinking that some people did not get their cholesterol taken care of because they had a high HDL, even though their LDL was also high, is old thinking. We're now recognizing that the action is with LDL, and the action is also with people who have high triglycerides. And especially if you have high cholesterol and high triglycerides, your risk is higher than average. So our job is to make sure that we individualize risk assessment for every patient who comes to see us, and then provide for them the best of dietary therapy, exercise therapy, and then based upon their risk, and we have ways we can assess risk, we then consider whether a statin or whether statin plus other medicines are going to be useful. Our job is to get them on just the right amount of treatment that's going to prevent cardiovascular disease from developing, but not more treatment than is necessary.
Thank you, Dr. Oranger. Dr. Lamelas, I have just been diagnosed with a leaky valve and I'm asymptomatic. How long should I wait before surgical intervention is needed?
Right, that's a great question. And you know, we've learned a lot over the last decade on this. And if we look, we have to look at the different valves as well. In the past, you know, the recommendation was to wait till you begin to have symptoms. But we know specifically, let's take the mitral valve. The mitral valve, we know that if the patient has severe mitral regurgitation and they're asymptomatic, if we could offer them a mitral valve repair with a greater than 95% chance of a repair, that patient should undergo surgery because that will improve their long-term survival. What we don't want is the patient to be symptomatic with severe mitral regurgitation, because that will lead to multiple readmissions with heart failure, and the mortality rate of that patient will go up significantly. So we know today that, again, no matter what the age of the patient, if they have severe mitral regurgitation and that we could offer repair, that patient should go to surgery. And another added benefit is that we could do it through a minimally invasive approach. And one last thing I want to mention is that we have just received the Mitral Valve Reference Center Recognition Award, and that's awarded to hospitals that demonstrate superior outcomes in mitral valve repair and have a commitment to reporting the quality measures specific to mitral valve repair. And this is an award given by the American Heart Association and the Mitral Foundation. And there's only 12 centers in the United States that have been recognized as a mitral valve reference center. And what a reference center is a center where, again, as I mentioned, we have great outcomes and great results, not only in surgery, but also you know, during their hospital stay and back to a normal lifestyle. And also this mitral valve repair has to be durable. So these patients get echocardiograms at 3 to 6 months, and the repair has to be perfect, or just even with a mild leak is acceptable, but or a trace leak, not a mild leak. But we are recognized as one of those centers, and again, that's where you want to go if you want the highest chances of having a mitral valve repair. Which, by the way, having a repair it has the best short and long-term outcomes for the patient, less risk and better survival benefits with a repair versus a replacement.
Dr. Lamelas, thank you and congratulations. That's again testimony, another wow factor for what we do in cardio, in the cardio division. Dr. Lowry, we just had this sent into us. Red wine being particularly helpful for the heart. Is this true? Is it debunked? Give us the skinny on this one.
Only a bottle a day, Tony. I'll let Dr. Oringer go into that, but yes, there is some benefit. Some benefit has been shown to a glass or less a day.
Yes, in fact, those who kind of are used to the idea of drinking a glass of wine or a single drink of alcohol per day, in large populations tend to have lower cardiovascular. However, there is also a school of thought that says it may be better for people not to drink any alcohol at all. I tell people that if they find having a drink a day is fine, makes them happy, I have no trouble with it. But I also tell them that I'm not going to specifically recommend alcohol intake to reduce the risk of cardiovascular disease.
Thank you, Dr. Lauer and Dr. Oringer. And Dr. Oringer, we're going to keep you here. This just sent in to us as well. I'm 65-year-old male who had triple bypass at the age of 42. I have been on Simvastatin since then. While my cholesterol has been well controlled, I understand that this statin is out of vogue. Should I be switching?
Well, it's a question I'm frequently asked, and that is, there are older statins like Simvastatin or lovastatin or even pravastatin that have been around for many, many years. And if a patient comes into me taking one of those medicines, I'm always asking myself the question, is their LDL cholesterol as low as it should be? And secondly, is this one of the medicines where there may be potentials for drug interactions and therefore other medicines might be better? I do not prescribe the use of Simvastatin. There are other statins that I use that are stronger, more effective in producing good effects long-term and have less likelihood for drug interaction. On the other hand, I do have some patients in my practice who are taking Simvastatin who have very low LDL cholesterols, are tolerating it well, and have done well for a long period of time. And under those circumstances, I don't fix what isn't broke, so to speak. So it all depends on the patient. But in general, it is an older drug. And in most cases, when I see these patients, I usually make changes, except in those who are extremely well controlled.
Thank you, Dr. Oranger. Dr. Lamelas, after I get a stent, when can one stop taking medication?
Right. So just to clarify, I do not implant stents because I'm a cardiac surgeon. I'm not an interventional cardiologist, but that specific topic has also been with a lot of controversy over the years. Some recommend for a month, 3 months, 6 months, a year, and some even longer. So I don't think the jury's out, but also there's many different types of stents, and some stents require longer anticoagulation than others. So again, I personally would say not that to take aspirin and Plavix or Brilinta for at least a year. That's my recommendation. But again, it depends on who you speak to.
Great. Thank you, Dr. Lamelas. Dr. Lowry, this was just sent in to us. Give us the latest information on aspirin, because now we're hearing that a daily low dose aspirin can actually be harmful. What are your thoughts?
So pertinent to women, and there are some differences in primary care. So that is therapy we give to people without known heart disease versus secondary preventive care, which are therapies given to patients with known heart disease. It's been shown that an aspirin a day in women less than 65 years of age that are healthy, live a healthy lifestyle, can actually cause more harm, such as irritating the inside of the stomach and causing bleeding. So once again, if you're a healthy woman and you're on the young side, you do not need to take an aspirin. There's been studies have shown there's no significant benefit and possible harm. If you're over 65, you need to have this discussion with your physician, because there are some cases where it is indicated and you accept those risks, but the benefits always have to outweigh those risks. So once again, less than 65 for healthy women, not indicated.
Thank you, Dr. Lowry. Dr. Oranger, are there any non-medication treatments for familial hypercholesterolemia?
So familial hypercholesterolemia reflects a genetic predisposition to very high cholesterol. In fact, the problem is that these individuals are born with half the normal number of parking spots for cholesterol in the liver. And as a result, that cholesterol has nowhere to go and therefore just passes into the body tissues and, most worrisome, into the arteries that supply the heart. So most of these individuals always should be on good cholesterol lowering treatments in terms of diet and exercise. But in fact, it has now been shown that those people with familial hypercholesterolemia, that is the genetic abnormality causing very high cholesterol, if they're effectively treated with statins and usually with other cholesterol lowering medications, can have lifespans that are very similar to that of people who do not have high cholesterol. So it's a very exciting time, because these individuals in the past used to die around 15 to 20 years earlier than those who did not have this very high cholesterol disorder. Now with these treatments, we can literally reverse the great majority of that.
Great. Thank you, Dr. Oranger. Dr. Lamelas, I'm sure this is something you're asked quite often. Is whole food plant-based diet the best for after CABX4?
Well, I'm really not asked that question that often, in all honesty, because that's more of a question that's directed to Dr. Lowry, Dr. Oranger. But yeah, plant-based diet has been shown to be the most effective diet to decrease coronary disease as well as renal disease as well. So it is recommended. The problem is it may not be that easy to follow for every single patient, but it is the best plant diet, the best diet, plant-based diet.
Right. Thank you, Dr. Lamelas. And Dr. Lowry, this was just actually sent in to us, so it kind of dovetails what we were just talking about. Why aren't more cardiovascular care experts encouraging people to be vegan, considering that animal products contain cholesterol and high amounts of saturated fats, both of which are large contributors to heart disease?
Well, it's easier said than done. We can say a lot of things, okay? But again, it's expensive to eat a plant-based diet. It's harder to cook and feed a whole family, especially with small kids. So it takes more effort, more cost, but you will gain more health by doing so. But overall, we're in a busy lifestyle. We live in fast food lanes. There are no fast food vegan restaurants that I'm aware of.
Yeah, I want to make a comment on that. So, you know, one of the best ways to help people to know what is healthier is to talk to them about thinking about adding 1 or 2 meals per week in which they are not eating animal-based products. So if you, and we're not really talking about pizza with pepperoni either. I mean, there are really good meals that are available to people, lots and lots of dietary resources that can be found that can help people to add an occasional plant-based meal to their diet, and any little thing you can do to make a difference can help. But in fact, the Mediterranean diet, where people are eating whole grains, more olive oil, salads, lots of vegetables, fish, low-fat dairy products, that has been shown to clearly reduce cardiovascular risk and enables you to remain in the mainstream of life. So it's a good option for many people to consider.
Thank you, Dr. Oranger. We're going to keep you here. We have this question for you. Could the long-term use of statins cause a significant calcium score that is over 900?
Well, that's a wonderful question. You know, interestingly, and it's important that people understand this, people who take statins over time may actually turn out to have higher calcium scores. But the reason that this happens is that statins help take soft plaques in the arteries that don't have calcium on top of them and make them harder, but that makes them less likely to crack and cause a heart attack. So the reason we know that people with high calcium scores are at increased risk is not so much because of the plaques we see, but people who have lots of calcified plaques have lots of soft plaque, and they're the ones that are likely to break and cause heart attacks. So in fact, in some people, statins can actually increase the calcium score over time to a modest degree. But even despite that, there's clear benefit for those who have a lot of coronary calcium to take statins because they help to make those plaques less likely to break and cause heart attacks or strokes.
Dr. Oranger, we're going to keep you here because we just have this in. Are there treatments or methods available to reduce calcifications in the arteries?
Well, in fact, we're not so worried about calcification in the arteries as we are why the calcification is present. The reason the calcification is present is because there's cholesterol in the artery wall. So in fact, if there were no cholesterol in the artery wall, there would be no calcification. So therefore, we don't worry about the calcium per se. We worry about what underlies the calcium, which is cholesterol. And the treatments that we've talked about, good dietary habits, good exercise habits, statins, ezetimibe, and PCSK9 inhibitors, and now this new medicine, inclisiran, sucks the cholesterol out of those plaques, making those plaques more stable, less likely to crack, and reduce the risk of heart attacks.
Great. Dr. Oranger, thank you. Dr. Lamelas, any new advances in ablation close to a St. Jude metallic valve?
Well, there's 2 types of ablations, one done with a catheter approach, which again, I don't do, and one done performed through a surgical approach, which I do perform, but the catheter-based approach is usually what's done by the interventional cardiologist, and that's probably the first approach if someone has there's different approaches to atrial fibrillation, for instance, but if the patient needs an ablation, the first approach would most likely be a catheter-based ablation, which a catheter is passed through the groin and into the heart to try to create what we call a lesion, which would redirect the electrical current in the heart. When I perform this operation, it's through, again, a minimally invasive approach where I would do it directly and cause these lesions to, again, redirect. It's called a maze operation, the surgical approach. So what we do is we try to redirect the electrical current in the heart in a normal pathway to avoid this atrial fibrillation. When it's done through a surgical approach, we don't worry about a valve in the area because we're nowhere near the valve. When it's performed with a catheter, I mean, it still could be done, but it has to be modified to avoid getting near the valve because we either use heat or we use or we freeze the area or we heat the area. So it depends on the energy source and again the way it's performed. But there is no contraindication to have it done if you have a valve implanted.
Thank you, Dr. Lamelas. Dr. Lowry, why does blood pressure tend to be higher when you wake up in the morning and what can be done about it?
Get a better mattress? Just kidding. Basically, it involves around our hormonal release and the way that adrenaline starts to increase after we wake up. Both of these things will drive a higher blood pressure in the morning.
There you go. That's nice and simple and to the point. Dr. Oranger, we have this just sent in. What is considered high cholesterol? Is 195 high?
Well, that brings up the question of which cholesterol measure do we use? And we hear of total cholesterol, we hear of HDL cholesterol, and we hear of LDL cholesterol. LDL cholesterol today is what we best focus on to give us information on cardiovascular risk. So the concept of total cholesterol is pretty much outdated these days. We think about LDL cholesterol and we think about triglycerides as determining risk. And in general, we like to see the LDL cholesterol in healthy individuals less than 100. For people who have established cardiovascular disease, we like to see the LDL cholesterol less than 70. And for those who have had coronary disease and stroke or coronary disease and artery blockage in the legs or recurrent cardiac events, we like to see the LDL cholesterol less than 55. And those can all be well accomplished with good diet and exercise, statins, ezetimibe, and when necessary, a PCSK9 inhibitor.
Great. Thank you, Dr. Oranger. We just keep coming back to diet and exercise, don't we? It seems to be the magic bullet. Dr. Lowry, are there any technologies or therapies coming that can help rebuild damaged or dead scarred heart muscle?
Certainly not my area of expertise, but I have been involved in and still am involved in a number of stem cell trials going on at the University of Miami. And some of those trials have had promising results of showing how we can rebuild muscle tissue, both when damaged by a heart attack or other things. But there are medications that can also what we call reverse remodeling. Remodeling of the heart is a bad thing, just like it can be a bad thing in your home at times. But medications have been shown to reverse some of this remodeling. Specifically, the heart is shaped like a football, given that this Sunday is Super Bowl Sunday. But remodeling occurs when the heart changes from that football to a basketball. And then it doesn't work well. It doesn't pump adequate enough blood. So by giving these medications, specifically beta blockers and ACE inhibitors, some of the participants on this Zoom meeting may be on those. They can actually reverse or reshape the heart back to a football shape. So medications help, as well as the research in stem cells going on now.
Great. Dr. Lowry, thank you. Dr. Lamelas, this was just sent in. I just celebrated my 1-year anniversary of total removal of the percudarium performed by you, Dr. Lamelas. My recovery benchmarks have surpassed every expectation that my PCP had envisioned. One area that is lagging is the recovery of weight and muscle loss. I've read that patients who have cardiac events tend to have unintended weight loss. Can you tell me why this happens?
Well, I think the procedure was pericardiectomy, which is a resection of the pericardium. And that happens when we normally do that when someone has a constriction of the pericardium and has multiple cardiac effects. But, 1 year out, it's pretty long. I mean, it's at this point, you should be back to a relatively normal lifestyle. So, exercise, diet, I mean, all those things are important. If, we know that if patients don't exercise, they will have muscle loss. So, and we see that a lot in elderly debilitated patients, but somebody who's relatively young, going on a good diet and exercising, I think that patient should recover relatively quickly.
Well, that is going to be our last question of this evening. We thank you for all of your questions. Dr. Lamelas, we'd like to hear some final comments from you, sir.
All right. Well, I want to thank you, Tony. You did a great job in moderating, and we always enjoy seeing you. And I want to thank my esteemed colleagues who are, I mean, I think every question that was given to us and the responses have been excellent. I think everybody is. I've even learned a lot myself tonight, and I think the important thing is that we continue to learn every day. And I want the viewers to know that at UHealth Tower, our goal is to provide excellent care and to continue research and try to advance in the field of cardiology and cardiac surgery. And we truly continue to innovate and provide world-class expertise. And having said that, we are one of the busiest centers, not only in Miami, but in the state. And we're proud to say that we do have one of the lowest morbidity and mortalities, as well as length of stay, again, not only in South Florida, but in the state and in the country as well. And it goes without say that the generosity that everybody gives, the philanthropy that we have at continues to help push and breakthrough research and deliver multiple treatment options, and it continues to support not only the clinical aspect, but also the science in cardiovascular care and research. And we're very determined to continue to do this. And our goal is not to accept mediocrity and be the best in cardiac care and in cardiac surgery. And I want to, once again, thank the panel and Tony and everybody who's been on here tonight. And hopefully we can do this more often and continue to serve our community. Thank you.
Thank you, Dr. Lamelas and Dr. Lowry and Dr. Oranger. Where did this hour go? I mean, it's amazing how quickly that flew by. And once again, I think you'll all agree with me that we are so blessed and so fortunate to have such amazingly talented and passionate doctors right here on our campus. We truly hope that tonight's In the Know gave you valuable and beneficial information. It really was an incredible hour. Please remember that a full recording of this program will be posted online. Look for the link in the coming days. And in a moment, you're going to see a survey about tonight's town hall on your screen. Please, it takes less than 30 seconds. I've done it before. And what this does, your feedback is going to help us understand your interest and help us improve our program. As always, we wish you and your family nothing but good and great health. And remember, it's always about the you. Good night, everyone.